our communities of practice in Scotland, share with you where we've been, our journey to where we are today. Igor is going to tell you about some research he did by talking to various different people within our communities of practice. And if we've got time, we'll get you to have a chat about what that means for you, but we may not have time for that. And then I'm just going to tell you a little bit about the practical support that my team offer in how we actually go about developing these communities and supporting them. So what I wanted to show you was a map of Scotland, just to introduce, set the scene a little bit about what it's like. So we have a map of Scotland here, which we don't have, but just to highlight that we have 14 health boards in the NHS in Scotland. And they obviously are all working to whatever dictates by the Scottish Government, but they are quite independent, and that's where work with communities really comes into its own, because of the fact that they haven't got a shared IT system, they haven't got any ways to really communicate with each other particularly well. There we are, there's our 14 health boards. As you can see, some of them are very, very wide geographic spread. And so therefore, again, using communities can be a benefit for that. We have 8 special health boards. Now, I'm from NHS Education for Scotland, which is one of the special health boards we have. And it has a remit, as you would expect, around education, supporting the education of all staff in the NHS. And my role within it is within Knowledge Services. And the Knowledge Services group provides access to the evidence, to the evidence base. We came into NHS Education in 2003 with the main aim to provide an electronic library for all the staff. And we provide that through a website and a family of websites called the Knowledge Network. And through that, staff can all access all the subscription content of the journals, the books, the databases. And that means that we have equity of access across the whole of the health service, all local authority social services staff, through the third sector and the independent sector. So virtually all staff who have any contact with NHS patients have access to the evidence base. But when we came right back from 2003, we really recognised that not just access to the evidence was important, but it was supporting people to actually use it and supporting people to provide some of that evidence, because the published evidence itself isn't enough, as quality improvement always tells us. You need to have experience, and it's the evidence from people's experience that's really important. So we're of course moving towards integration, where the 14 health boards are going to have to work with the 42 local authorities and create these partnerships. Another opportunity for our communities of practice to really be able to support that development. I brought some quotes. We've done a review recently of our communities of practice. It's maybe quite hard for you to see on the screen. I'll just read a couple of them. We have a community of accountable officers. And these are the Controlled Drugs Accountable Officers Network of Scotland. And it has found the community a really useful way to have a single repository of stored, approved documents and then be able to signpost practitioners to it. We have the Highland Links Practitioner Network, which that's a community of people who are delivering a programme, and it enables the core team and the specialists to share resources across a diverse geographic area. We have the AAC, Right to Speak community, and that's been very useful to build peer relationships across existing partnerships. So it's a very, very wide range of staff involved in alternative ways of communication that's required. We've got the Borders Research Forum. We've got the Learning Disability Speech and Language community. And we have a number of, this is an example, the Dementia Managed Knowledge Network. We have a number of them, which are really networks of a number of different communities of practice. So within the dementia, we have 18 communities of practice, and we have about 492, we have 492 members of that particular community the last time I had a look. So it's a very different, it really is a network of people who are interested in dementia, but within that you've got very focused communities. So for example, we've got the Dementia Supporting Change community, which is a programme of masterclasses who use the community website, and then within that you've got different areas have learning sets and they utilise the community to support those learning sets. So that was just to give you an idea of some of the feedback we've had from our communities. So just a few facts for you, just with some photographs, just to sort of to ease the facts. So I've gone a bit too fast there. We have 196 communities use our website, our technology. Now, we focus very much on supporting communities, whatever the technology they use, but we do provide them with a platform that they can utilise, and we call it the Community Builder Toolkit, and that allows them to create community websites. We've had various technology platforms over time that we have used, and as if technology's moved on, people's user expectations have moved on, we've had to improve these platforms. But I can say to you that every time you change your platform, you do lose a few people. It is quite a challenge to do that. We have, that number there was 8,300 or so. That's the average unique visitors we have on all of our community websites every month. On an average for 2014. 45 is the number of training sessions approximately that my team have conducted, either face-to-face or over WebEx. We use a lot of WebEx. I don't know if you use WebEx, that's with the phone and the computer. We do a lot of work with them using the WebEx with our communities, either around supporting use of the technology, but also about actually developing their communities. And lastly, just to give you a range of the different topics that our communities cover, that's how they've been grouped under some main headings. So our quality improvement, I know that this is just something that's close to your own heart, so I thought I would just show you what we have. Quality improvement is driven by a collaboration between NHS Education, Healthcare Improvement Scotland and the Scottish Government. And then, of course, there are local hubs and local teams all supporting it. And we have our Quality Improvement Hub website, which is part of the Knowledge Network, part of our whole family of websites that we provide. And then you've got a networks and communities element to that. And within that, we then have a lot of the quality improvement work is conducted by collaboratives. And these collaboratives are for particular topics. So you'd have patient safety collaboratives around about maternity, sepsis, etc. And each of those collaboratives have a community website. So that's the screenshot for the maternity one, for paediatric care, and then you've got one for sepsis. So they utilise that. But they're a really good hub and spoke type picture of communities of practice, where you've got lots of local communities all coming together, operating around a particular topic locally, and then every so often they have national learning opportunities where they come together and share what's happened locally. And I think it's a really successful way of operating communities across the country to make sure that what's happening in different places and they're sharing the learning from that. I just wanted to say a little bit about our current strategies around why we support communities of practice and why we think it's really an important element. We have had a number of different strategies over the years. We've had knowing to doing, we've had sort of involving partnerships, and we currently have knowledge into action, and they all have that focus on getting that evidence used in practice. Currently, our knowledge into action strategy, the review for that looked at all the models of how people get knowledge into action, how people, knowledge translation, whatever you want to call it, evidence-based practice, all of these different terms. We reviewed the literature about it, we looked at models, and we came up with our own model for getting knowledge into action for Scotland's health and social services. And that really highlighted that you needed to have various elements, being evidence search and synthesis was very important. Creating knowledge in packages for actionable formats was very important. The social use of knowledge was important, and then building capacity and capability, both at personal and organisational levels. So our focus of our work has really been trying to meet these four different elements. And for the social use of knowledge, one of our main routes to do that is through our communities of practice work. So it's really given us further impetus to continue focusing on communities as a useful way of helping bridge that knowledge practice gap, helping people to actually use the research in practice, etc. Because it really brings the published knowledge in together with the knowledge from experience. So just as quickly, just to show as knowledge into action as a process. So we know that we've got to combine all that knowledge together from the literature, from the guidelines, from the books, but also from people and experience. And we have to have social interaction, social learning, create the actionable knowledge formats. That's a co-production activity, and then you're more likely to get knowledge into action. And I think importantly for how we actually can facilitate that to happen is the fact that we work very, very closely with a network of librarians in the NHS, and they are available locally, and they collaborate together in order to provide a national service. And so we see them as being really crucial to the process.